you, my senior colleagues and friends and guys. I'll be dealing with a topic which is a very important topic in our clinical practice, which we as interventionists ourselves ignore. But I think this forms the backbone of a health and clinical medicine in every cardiology decision that we take for our patients. So I'll just give you a brief overview of echocardiograms. It's just a 5-10 minute talk, but I'll run you through the whole basics of echoes, the different types of views that we need to make, and the common diagnosis. So what is echo? It's it's an ultrasound of the heart using an echo machine, which is slightly more advanced, equipped with a range of probes. Range of probes can include adult probes, pediatric probes, and vascular probes. Vasculars, especially for our carotid system. And basically, we are dealing with transthoracic echo here. There's another type of echoes which we as cardiologists do called transesophageal echoes, in which you put an endoscopy-like apparatus inside and take transesophageal views of the different chambers of the heart. But I'm dealing with only transthoracic echoes today. So these are the different types of echocardiograms. Our main focus is on the first three. M mode, 2D, which basically is our basic echocardiogram with an ultrasound, and we're dealing with all the chambers of the heart. And a color Doppler, in which we see for the valvular regurgitation. The other things are much more advanced, which specific sonologists or echocardiographers deal with. Tissue Doppler imaging, contrast echoes, 3D and 4D echoes. What an echo can do, how can it help us? Basically, for every myocardial infarction in an angina patient, it helps us determine the chamber size, thickness, and function. Thickness, it helps us in our hypertensive patients to see for left ventricular hypertrophy. Chamber size to diagnose dilated cardiomyopathy, and function to see for LV dysfunction, post-myocardial infarction, or in idiopathic cardiomyopathies. Assess our cardiac valves, pick up mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, and likewise. Hemodynamics, if a patient comes to you with acute pulmonary edema, even with normal LV function, patients can go into heart failure. So we look at PA pressures, right ventricular filling pressures. What our JVP used to give us, or still gives us in clinical practice, our echo helps us even further. Congenital heart diseases, a cyanotic or acyanotic baby at birth, an echo is the only modality and the best modality to pick up and make an early diagnosis. And some extracardiac shunts can also be picked up on echocardiogram. Well, who can perform it? All of us can perform it as cardiologists, as physicians. We just need to be well trained in it, because a little knowledge is a dangerous thing. If there are so many physicians in town who are doing better echoes than cardiologists, only because they are dedicated sonographers, it at least takes a year to pick up good echocardiographic skills, as my colleagues here will agree. And after that, it's mostly very easy. We have technicians and cardiac sonographers who assist us in our hospitals. They are properly trained but need to be supervised. Well, how does echo work? This is basically physics here. Uses high-frequency sound waves, also called ultrasound, that can provide a moving picture. That's what's different than in an echocardiogram compared to an ultrasound abdomen, because it's moving structures here. A moving picture of your heart. The sound waves are sent to the body with a device called a transducer, which we put on the chest wall, and the sound waves bounce off the heart and return to the transducer as echoes. These echoes are converted into images on the television set, which we visualize. This was in earlier echocardiographic days. The M mode, one-dimensional echocardiogram, was very, very common, which is not really much used now, but still gives us good information. This is our main modality called 2D echo, in which we take a moving picture of the heart and see all the chambers and the valves. 2D echo is one of the most important diagnostic tools for doctors, and pretty easy to pick up and learn. Doppler. When you put a colored Doppler on the heart, we can see for valvular regurgitation. We just see the flow of blood going from RA to RV, LA to LV, but it's regurgitating back into the RA, or the LA from the LV to the RV, or going back into the LV from the aorta to diagnose aortic regurgitation. So how do you take echo images? There are a few standard images, four standard views. This is something called the parasternal long-axis view, in which we see the LA, the LV, and the RV, and the aorta. This is a parasternal short-axis view, in which we take a cross-section of the heart. The apical four-chamber view, which is the most commonly used view to diagnose LV dysfunction and valvular regurgitation, in which we see all four chambers of the heart. We call this the cardiac surgeon's view because mostly cardiac surgeons don't understand more than this. So whatever information you need to give them, you give this through this view, in which you can visualize all four chambers of the heart. And apical two-chamber view, in which we see the LA and the LV. A few other advanced views. A suprasternal view in which you can diagnose from the suprasternal notch. You can see the arch of aorta and the descending aorta and the three major vessels coming out, and you can diagnose coarctation of aorta as well. We can do a subcostal view as well from infraxiphoid and look for pericardial effusions and LV function, especially in obese and COPD patients in which we don't get good chamber views from the routine positions. This is the MO, the one that I talked to you about. This is a two-dimensional, the one-dimensional view in which this is not a 2D view, but just a cross-section of the heart. This was a little more obsolete now. These are further advancements in echoes called tissue Doppler and spectral tissue Doppler, done mostly by dedicated echocardiographers. Contrast echo. And now coming to the latest 3D echoes. Really hasn't taken off. It came around 7 to 8 years ago. It really hasn't taken off in cardiology circles. A little more cumbersome to do. Does not give as much information as we thought it will. 2D echo still remains the backbone of day-to-day practice. This can help in patients who require mitral valve repair or in rheumatic heart diseases and congenital heart diseases, but not routinely for our cardiac day-to-day practice. A little more cumbersome, time-consuming, and not really cost-effective. Further, a few advancements in the field of echocardiogram. 4D is also coming, but really not taking off compared to the previous modalities. So, like I said earlier, this is a transthoracic in which we place a probe on the chest wall, and the other is transesophageal, which we put a transesophageal probe like an endoscope and take views of the cardiac of the heart from the esophagus. This is a moving 3D echo. This is compared to a normal echo. So it really gives much more information, but you can get 90 to 95% of routine information that you require in a 2D echo. Just summarizing various views that we take a little further. This is what we call the parasternal long axis view. This forms the first view of the heart. As the name suggests, it's taken from the parasternal area and gives us the left atrium, the left ventricle, and the right ventricle and the aorta, and corresponds to the anatomy like a cross section. This is a short axis view in which we see the LV function, a cross section of the LV. This is a very good modality to look at the mitral valve, the aortic valve, and the LV function. This is what I call the cardiac surgeon view again. This is the four chambers we have: the LA, LV, RA, RV, the mitral valve, the tricuspid valve. One thing to understand here is it's opposite to what you guys think the heart lies in. So it's upside down, so the LA and RA are down, and left is right. So LA, LV, RA, RV in the parasternal and in the apical four-chamber view. This is again a short axis view giving us a view of the aortic valve. These are the, like you all know, the aortic valve is tri-leaflet. So if you want to diagnose bicuspid aortic valve, congenital bicuspid aortic valve, this is a very good view. And we can make out the aortic cusp separation as well, whether the valve is opening or there is aortic stenosis. Okay, like I said, this is a good image of a colored Doppler, which helps us in diagnosing mitral or aortic regurgitation. So this is a colored flow or the blood flow which is coming from the LV down to the LA. Normally, as we all know, the blood should flow from the LA to the LV and further on. This blood is regurgitating back to the LA. So there's a severe mitral regurgitation which can be easily picked up on bedside. Again, aortic regurgitation, this is an apical 5-chamber view, LA, LV, RA, RV. This is the aorta. So the LV should have pushed blood into the aorta, rather the blood is coming from the aorta back to the LV and demonstrating aortic regurgitation. Again, a few more images here. This is a ventricular septal defect. Again, the 4-chamber view, LA, LV, RA, RV. This is the intraventricular septum. You see some color flow across the ventricular septum, a classical VSD. can be at birth, can be post myocardial infarction, ventricular septal rupture. Well, how fascinating is an echo? I'm sure everybody wants to learn echoes, but like I said, if you need to practice echoes, you need to be very good at it because they can very easily misdiagnose if you're not very trained. This is a very common thing which is missed and can be catastrophic. This is a large pericardial effusion outside the cardiac ciliate. As we all know, RV diastolic collapse is a hallmark of cardiac tamponade. Look here, this RV and RV collapse in these diagrams. The pericardial effusion is causing tamponade and pressing on to the RV, specifically RV diastolic collapse. Well, a few more examples. This is a large pulmonary thrombus here. Can throw an embolus. This patient needs to be on anticoagulation. If missed, we can cause a stroke even in spite of treating a myocardial infarction. Again, a post-myocardial rupture in the septum. You can see current flow across the ventricular septum. This is okay, let's bring back a few slides. This one is a congenital heart disease. You see a large defect in the ventricular septum, the atrial septum. A congenital heart disease with large VSD and ASD requires urgent pediatric cardiac intervention. Again, this is a 3D echo with a large myxoma. This is a mitral stenosis, a large myxoma, left atrial myxoma. These things can be easily picked up on 2D echo. They, however, look much nicer on 3D. But like I said, if you want to invest in the 2D echo, unless you're in a big corporate setup where the corporate organization buys it for you. Thank you for your attention. I'll just be showing a video before I finish, just to explain better what all I've talked about. Just require a couple of minutes more of your time. Okay, this is how we do basically the cardiac surgeons view. They have a 4-chamber view. So basically you require a transducer and you require a lot of jelly. And where we feel our apex beat, that's where you need to put your transducer. And this is a classical 4-chamber view on a 2D echocardiogram. The LA, the LV, the RA, the RV. The LV function is very good here. Mitral valve is good, there's no mitral stenosis. If you put color onto this, we can look for mitral regurgitation and tricuspid regurgitation. The tricuspid regurgitation is where we look for the PA pressures. This is the tricuspid valve. This is where we look at RV filling pressures, the pulmonary artery systolic pressures, especially helpful in patients with COPD. I get a lot of reference from my chest physicians to look for pulmonary hypertension. Again, this view remains the gold standard for a lot of information that we can draw.